Good afternoon. My name is Alex. I am a second-year resident at the New York College of Podiatric Medicine residency program, and this is my case presentation. All right. So we have a 65-year-old male with a body mass index of 28.37, classifying him as overweight. Past medical history was significant for uncontrolled type 2 diabetes mellitus. 10.1% was his last hemoglobin A1C out of October 2024. It's since been increasing while under our management. Also has a history of hypertension, hyperlipidemia, and hypothyroidism. His current medications are listed here. He does not do illicit drugs. He's a non-smoker, abstains from alcohol, and lives in an apartment with his wife and has a stable home situation. All right, so patient came to the emergency department on September 15th, 2024, as you can see here, for evaluation of a new right foot ulceration. He was last seen in our podiatry clinic in 2023 for routine diabetic foot care. Over the preceding week, he noted progressive swelling to the right lower extremity, prompting an evaluation and ED visit. On arrival, his vital signs were stable, laboratory workup was normal, absent of leukocytosis. Physical exam revealed non-palpable pulses, normal temperature gradient, and mild edema surrounding the ulceration. Neurologically, the patient had diminished epicritic sensation. Dermatologically, as you can see here, he demonstrated a plantar ulceration overlying the fifth metatarsal with partial hyperkeratosis, an eschar and fibrotic, also with a necrotic base. On debridement, devitalized tissue was noted, and the wound probed directly to the head of the fifth metatarsal. Approximately 1 milliliter of seropurulent fluid was expressed and sent for culture. The surrounding tissues showed mild erythema and slight malodor. Plain radiographs can be seen here. It cannot exclude bony destructive indicating osteomyelitis, could not exclude. So we got advanced imaging so T1 hypointensity and T2 hyperintensity of the fifth metatarsal head and proximal phalanx, consistent with osteomyelitis. Also showed soft tissue swelling and edema. The patient wound progressed and serial debridements were also conducted in these photos. Okay. The patient's wound cultures returned MRSA, and infectious disease consultation recommended IV antibiotic course of vancomycin. Most importantly, vascular surgery consultation is here. Vascular surgery was consulted, and a non-invasive vascular studies revealed a right ABI of 1.33, indicating non-compressible vessels with an uncalculatable toe brachial index. Right lower extremity arterial duplex demonstrates stenosis of the anterior tibial and posterior tibial arteries, along with complete occlusion of the peroneal arteries. Based on these findings, the in-house vascular surgeon did not want to proceed with vascular intervention and said you have to go on to lose your foot and get a more proximal amputation. That patient did not want to go through with that. That patient heavily went against it. He wanted to keep as much of his foot as possible. Given the poor vascular supply, we thoroughly discussed all procedures. He said whatever it takes to go through, do it. But in October 24, the patient was evaluated by an outside vascular surgeon where a peripheral angiogram was performed. Imaging demonstrated patent flow through the right external iliac, common femoral, superficial femoral, and popliteal arteries with no significant narrowing. The right anterior tibial artery showed proximal narrowing and complete occlusion without reconstitution, which cannot be traversed through a standard antegrade approach. On December 13th, 2024, the patient underwent a retrograde Safari procedure, subintimal arterial flossing with antegrade retrograde inversion. Because we're at a vascular conference, I wanted to discuss this procedure a little bit with you. This technique is specifically used to treat complex chronic total occlusions when standard antegrade recanalization did not work, as seen before in our patient. Patient was a poor surgical candidate, no vein was available for revascularization, and extensive below-the-knee arterial disease was present, all of which is seen in our patient. This procedure involves accessing the artery both proximally and distally, as seen in the image to the right. You use a through-and-through floss wire to successfully allow for the angioplasty or a balloon or stenting to occur. Following intervention, a complete vascular exam showed palpable femoral and dorsalis pedis pulses with a non-palpable posterior tibial indicating two-vessel runoff. The patient was followed closely by vascular surgery, who noted hemodynamic improvement post-procedure. The patient subsequently followed up with podiatry team for local wound care. But approximately 2 months after the intervention, the patient's condition deteriorated during evaluation, with the wound showing signs of progressive necrosis, prompting the need for inpatient management. He was initiated on intravenous antibiotics, specifically vancomycin and zosyn, and a vascular workup revealed mildly decreased right ABIs. An arterial duplex ultrasound demonstrated occlusion of the right posterior tibial and peroneal arteries. Went back. Through a collaborative effort, the outside vascular surgery team was contacted, and he was transferred to an outside hospital system. The patient was transferred for further endovascular intervention. A unilateral lower extremity angiogram was performed with stenting. On completion, the femoral and dorsalis pedis pulses were palpable to the right, confirming improved distal perfusion. Although infection of the bone persisted, the successful revascular procedure allowed for improved patient chances of wound healing following surgical intervention. We proceeded with targeted amputation of the right fifth metatarsal head and base of the proximal phalanx to effectively remove the infected bone while preserving as much tissue as possible, leaving it up to the patient's wishes. As you can see here, we put a drain in, and this is the procedure. The patient has since been under constant follow-up with progressive improvement, noting, and this is him finally, noting significant improvement over time with this. The key takeaways right now are that we did a collaborative effort with outside vascular surgery team, including those throughout the healthcare system. When one says proximal amputation, there is always hope to look to the outside. Also, it's the value of listening to our patients. The patient did not want to go through a proximal amputation. He searched for outside, and he was able to heal. Additionally, it's the essential role of blood supply going to the lower extremity. The patient ended up mostly healing now, and by now he should be pretty good. Thank you.